Welcome everyone. Let me introduce you to my PhD topics, which will show you the benefits of the involvement of the clinical pharmacist in evidence-based medicines. I work as a clinical pharmacist for 7 years, and throughout my practice, my tasks are based upon the guidance of international guidelines, and my vision is that pharmacists have an essential role in multidisciplinary team, and they have an essential role in every ward. And to support this vision, I would like to develop official clinical pharmacy services in Hungary to standardize these, maybe across Europe. My project mainly focuses on management of pancreatitis. In the first, I would like to show you a possible new therapy to treat pancreatitis. In the second, I would like to show you that maybe a deprescribing of an inappropriate medication may enhance the patient's safety. In the third project, I would like to show you that maybe there is a preventative medication that can prevent post-ERCP pancreatitis. And the fourth project, I will take a step back, and I would like to show you the landscape of the clinical pharmacist in Europe. First of all, acute pancreatitis is the inflammation of the pancreas. Its incidence rates are a little bit low. However, depending on the severity of the episode, it can achieve very high mortality. To this date, there is no efficient pharmacon that are backed by evidences. And there is an emerging possibility named Ulinastatin, which is a urinary trypsin inhibitor that maybe show beneficial effects in the treatment of acute pancreatitis. It can inhibit several mediators that are proteases, and they are enhancing the inflammation in this acute pancreatitis episode. Our aim is to investigate the addition of ulinastatin to the conventional therapy, and our clinical question, does it have a superior efficacy regarding the mortality compared to the conventional therapy. Our results showed that this combination therapy can reduce the complication rates in acute pancreatitis. Namely, it reduced the multi-organ dysfunction syndrome by 60%, the acute kidney injury by 70%, and the acute respiratory distress syndrome by 70%. As you can see, we did a great analysis. It has got some flaws, for example, the low amount of available clinical trials, and in some aspects, high heterogeneity. We hypothesize that it is because the high heterogeneity amongst acute pancreatitis patients, they have got very different comorbidities. They can be also before healthy. So mainly, we hypothesize that this heterogeneity is due to this. Furthermore, the complication rates, beneficial effects of the complication rates resulted in the decrease of length of hospital stay. However, we reached only near significance in the mortality sections. However, it decreased the mortality by 45%. Our conclusion was that it's superior to the available therapy. However, there are more randomized controlled trials that are needed to investigate the effects of the ulinastatin. And we have a published article in this year, in October. Moving on with the second project. PPIs, proton pump inhibitors, are one of the most overused medicines all around the globe. It is also true for patients with acute pancreatitis as well. Recent analysis showed that on admittance, 20% of the patients, and during the hospitalization, 70% of the patients have been prescribed PPIs, mainly for stress ulcer prophylaxis. However, theoretically, PPIs can reduce not just the gastric secretion, but the secretion of the pancreatic juice directly in the pancreas. However, it was only some experimental studies with animal models and had controversial results in some aspects. Overall, clinically not supported the use of PPIs commonly in the treatment of the acute pancreatitis patients. However, there are no acute pancreatitis guidelines that contain PPI-related recommendation or avoidance. So we are the first to investigate the effects of the PPIs in patients with acute pancreatitis. And our question was that does these PPIs increases the rate of complication rates? Our results showed that the pancreatic pseudocyst rate were significantly lower in patients treated with PPIs, and this may be supporting the theoretical aspect of the mechanism. However, as you can see, we included randomized control trials and cohort studies because there were very low amount of studies, so we had to combine this. And it's only an assumption, and it's associated with a reduced pancreatic pseudocyst rate. There is no causation in this. Interestingly, we find that the gastrointestinal bleeding was more relevant in the patients treated with PPIs. However, we think that it's a false positive result. As you can see, the weight of the results came from the cohort studies, which are very heterogeneous population again. And in contrast, the randomized control trial showed differently. So there is inconsistency. However, I should mention, everybody knows that PPIs can prevent very good the upper gastrointestinal bleedings. However, there is a study that shows inverse effects regarding the lower gastrointestinal bleeding, so there should be much emphasis in the later research. And the results showed no significant differences on the acute respiratory distress syndrome. Furthermore, there was no significant difference between the two therapies regarding the 7-day mortality and the length of hospital stay. In summary, to treat acute pancreatitis with PPI is an off-label therapy. However, the PPI therapy can coincide with the pancreatitis episode. The strength of the study that we were the first to analyze this, the limitation is there are very small number of trials located only in China, and there was high heterogeneity, and further researches should focus carefully on the selected patient population. In this regard, we have submitted to the Journal of Scientific Reports, and we are waiting for the editorial decision. In the third project, ERCP is a minimally invasive procedure, and the most complication rate of ERCP is pancreatitis, and only indomethacin and combined with non-steroid anti-inflammatory drugs and aggressive hydration showed beneficial protective effects preventing PAP. And there is also an emerging drug, nafamostat, also a protease inhibitor that maybe show beneficial effects in preventing the post-ERCP. Our results showed that nafamostat can decrease the overall incidence rate of post-ERCP pancreatitis, and it can only decrease the incidence rate of mild PAP, and the moderate and severe, we did not find any significant differences compared to each other, the two therapies. However, these were one of the first analyses that showed almost a beneficial effect of this therapy. However, there is an emerging rate of prescription in Japan, so the implication for research should be a cost-effectiveness analysis, whether to determine the best possible place for this therapy. The article writing is in the final state, and we will submit it soon. And regarding the fourth project, we would like to investigate the clinical pharmacist role in Europe and Central and Eastern Europe. And for the clinical pharmacy services in Europe, it's a very young services. However, there is no official benchmarking system for measuring these clinical pharmacy services. So we would like to conduct a survey among clinical pharmacists to discover the most common practices, and later we would like to give an evidence-based standardized protocol for them to how to conduct and how to measure these services. We have 3 modeled questionnaires We will collect descriptive information, we will collect the clinical pharmacist relationship with the healthcare workers and the provided clinical pharmacy services, and we are in the distribution phase with this survey. Ending my presentation with the quote that never stop asking well-designed, well-constructed questions. Thank you for your attention.
May I ask, is there any generally accepted theory about the protective effects of proton pump inhibitors in pancreatitis?
Thank you for your question. It is also the same effect as in the gastrum. It directly can inhibit the pancreatic cells to produce pancreatic juice. However, in human, it wasn't investigated in deeply or in detail.
So the same transporter is expressed in pancreas?
Mm-hmm.
Yes.
Thank you very much. I've got two questions regarding on your first project. So the drug you examined is available in our country and in the European Union.
It is
pardon?
It is only available for Eastern countries. However, we can import it. It's approximately 2 to 3 weeks to import this medication, so it could be available.
Mm-hmm. Because the studies come from China, all of them.
Mostly.
Okay, and is it the same matter with the third project?
Yes.
Okay, thank you.
I just wondered that how do you proceed with your questionnaire? I mean, that how do you distribute that, and then how do you make sure that you will get back the replies?
Yes, we contacted in October the European Society for Clinical Pharmacists. They distributed it via their LinkedIn profile. It didn't get much attraction. In parallel, we contacted the Hungarian Society for Clinical Pharmacists. They directly messaged the fellowships, and it got much better attraction. Furthermore, we will establish connection with the European Association for Hospital Pharmacists, and they will distribute it in late January or early February. And we would like to get out a remember email for later on, I think in February, for the other associations to get some more attraction.